Good evening. I'm Dr. Kavitha Sakamuri. I'm consultant pediatric endocrinologist at Rainbow Hydernagar. At the outset, I would like to thank all the gender pediatric colleagues who have been referring cases for the last couple of years. Why have I chosen this talk? Faltering growth is a common pediatric problem with many untoward effects. More studies show that children who fail to thrive in infancy are lighter and shorter at school age with adverse intellectual outcomes. Weight faltering in the first months of life is particularly associated with these adverse effects. Infants with faltering growth also have a high prevalence of feeding problems. Growth failure is more common during infancy and toddler years than during any other stage of life because programmed growth rates and nutrition needs are very high during this period. So in medicine, we all believe prevention is better than cure. And I also believe I want to nip anything when it is in the bud stage. So growth has a long tradition of being used as a measure of young children's health and well-being. Weighing begins early at the antenatal clinic. With the expectant mother being anxious to put on just the right amount of weight for the optimum health for her baby. Scans measure baby's growth and parents are reassured if the gestation size appears right. Subsequently, parents are frequently asked after the baby is born, how much does she or he weigh? And visits to the well baby clinic can often convey success or failure to the parents in relation to whether the baby has gained weight. I just want to talk about how there are some myths that are associated with the faltering growth. At the turn of the century, the term failure to thrive was commonly used to describe children, often brought up in the foundling homes, who were taught to receive adequate food but still grew poorly. Gradually, it became assured that these children failed to grow because they lacked stimulation and love from their carers. Failure to thrive was divided into two separate categories: an organic cause for the failure to gain weight, or a non-organic cause found. And no organic was found, and therefore the loss was probably due to emotional deprivation, maternal deprivation, and or neglect. In faltering growth, most of the research up until the 1980s tended to focus on the distorted mother and child relationship, which was thought to be the lead cause rather than the children not receiving few calories. However, the current research in 1999 has shown that the majority of the mother-child relationship in families where a child has faltering growth are no poorer than in the families where children are growing normally. Now, the current research has moved away from the simple cause and effect model. Studies now have highlighted on the interactional perspective in which the multiplicity of factors may result in the faltering growth. And the main important thing I would like to say here is the two types of failure to thrive, non-organic or organic. Although they appear to be as though there are sharp divisions, they are not helpful, as these two categories are not mutually exclusive. Also, they usually have the same cause in that the child is receiving too few calories. And 50% of the children usually have a poor growth. And these are found to have a previously undiagnosed illness, and only a very small minority have a faltering growth because of either abuse or neglect. So the key message is dividing faltering growth into two categories, non-organic and organic, is misleading. Faltering growth is present in all the socioeconomic groups. Research indicates that the pediatrician shows certain misconceptions, thinking it is very less common in the highly affluent communities. So the expression to falter means to hesitate. Faltering growth is an observation without value judgment of slower than the expected rate of growth along an infant or toddler previously defined growth curve. Most recently, the preferred time faltering growth as failure to thrive has been associated with negative connotations of parents saying that they're failing in their job as care providers. So now we are using the word faltering growth. Faltering growth has an evolving history in terms of definition, methods of assessment, management, and long-term outcomes. The phenomenon first known as cease to thrive was in use in 1897 itself and has since been described as failure to thrive, growth faltering, or weight faltering. So faltering growth is a significant interruption in the expected rate of growth compared with other children of similar age and sex during early childhood. Faltering growth usually applies to young children, especially infants and toddlers, rather than the older children or teenagers. And this is a definition which you all can see. It's about the low centile of the length or the weight, or the crossing down of at least 2 centiles of the length and height, or the both, or a low height centile or a weight centile, or a height less than the expected for the parental heights. But these all have to be looked at for the appropriate age and sex. That's the key. How serious is the issue? The reported prevalence in pediatric patients ranges from about 5 to 50%. Those at high risk are below the age of 5 years. So which is the age group we call as early years. So the most common cause of faltering growth, in contrary to everyone thinks, is an inadequate nutritional intake, especially of the energy, protein, and micronutrients. And there is only a very small number of cases where you will see a pathological cause. So the faltering growth is rarely a disease-related condition, and it is often, when it is seen, it is multifactorial, and it may lead to potential short and long-term consequences for growth and development. So some facts affects all the socioeconomic growth, and it is due to insufficient calories. Feeding difficulties is most commonly the cited factor. Most cases of faltering growth do not have organic cause, in contrary to our beliefs. A minority of children may have neglect or abuse. Emotional deprivation is also a reason for faltering growth. So nature and nurture, both of them play an important role in the growth of the child. So the key message, as many as 50% of children under 5 years of age will experience an episode of growth failure at some stage of their life. So why is faltering growth important? Because it's not a specific disease, but it is simply an observation that the child is growing exceptionally slow. And it can sometimes reflect serious underlying problem. And pediatricians must recognize that most children with faltering growth look well and they live in the loving families. If poor growth continues, it may affect the parent-child relationship, and it then go on to develop long-term problems, including a probable developmental delay in the child. So I want to nip it in the bud. So faltering growth is a common occurrence, and pediatricians can play a key role in taking the failure out of the faltering growth. So supportive, regular well-baby clinics will not only empower the families to overcome this problem, may well help to prevent babies developing a worrying weight loss in the first place. Many children have a range of medical tests to eliminate organic causes, and this may sometimes be intrusive and inappropriate. And hence, we need to make a correct diagnosis before we embark on to investigating the child. So what's the burden? Parents may feel blamed for the child's low weight gain. Not only that, the growth in the infants and preschool children is a common cause for both parental and the professional concern. So today, the aim of my talk is to reiterate to the pediatricians to revisit what's the daily nutrition requirement of these children, how to increase their energy intake, and how to manage challenging feeding behaviors in these kids. Also to provide insight to my colleagues into various causes of faltering growth through clinical vignettes, and to raise the awareness of the endocrinologist role and delineate what pediatricians need to do and when they need to refer these children. The key message, we'll come to that. So in the newborn period, weight loss of up to 10% of birth weight is common in the early days of life. And this is basically because of the physiological phenomenon of fluid loss. Birth weight is usually regained before 3 weeks of age when feeding is established. Faltering growth after the early days of life is characterized by a slow rate of weight gain than expected. Investigations for faltering growth involve a clinical, developmental, social assessment, and full physical examination. Initial management just includes strategies to increase the energy intake and advice on managing feeding behaviors. So, faltering growth describes a growth pattern. It's not a diagnosis, and an underlying cause must be identified. And this is my favorite rainbow, where we say, together, let's begin our 1000-day journey. And that's the key time of the child's growth and the development also. Now, let's identify the causes. So in the first month, the focus has to be on the mother's well-being, physical, social, mental, emotional, and nutritional. Focus on the baby who's establishing the breastfeeds, here comes the role of the lactational consultants, because the breastfeeding is where the new mothers will need a lot of support. Now, they're all nuclear families. They don't have any adults with them most of the time. So establishing these feeds and helping them with the breastfeeding, the lactational consultants are a good help. And then they should be attending regular well baby clinics. So helping the mother with the breastfeeding, it's a very sensitive area. Be a rainbow, do this by simulation. So we presented a poster at Similar Sport. Simulation with low-cost smiley ball for the priceless smiles of successful breastfeeding is the title. And this was a baby of our neonatal colleagues, Dr. Nilima and Dr. Rajeshri, as well as the nursing colleagues. I've just presented this on their behalf at this conference. So the second category of the children that come to all the pediatricians is with this: my child doesn't eat, doctor. And this is what all these parents' concerns is about. So what do you think is the difference between eating and feeding? So children eat, parents feed. Do you all know there's something called as parental feeding styles? So do you think the parents know what their feeding style is at all? And what is the implications on the child's feeding habits or the feeding practices? So the parental feeding styles. So the first picture on your left, what do you think it is? It's called responsive feeding style. So the second one on the right at the top row, what do you think it is? Controlling feeding style. Indulgent feeding style, which means all the family members are behind this child, they want to get him to eat. They are giving so many alternatives to the child. That's called indulgent feeding style. The last one is a neglectful feeding style. As you can see, the bottle is given and the father is on his phone. As is the parental styles, there are also types of children. So what do you think the first child? So that's a child with selective intake, which is a picky eater. So the child with fear of feeding for whatever reasons, he may not like the textures, he's not used. And again, fear of feeding, neophobia, is very common in the initial period of weaning, because these children need to get used to all these new foods. So at least 20 or 30 times a new food has to be tried before the child starts liking them. And the child with a limited appetite. So there are children whom we call as infantile anorexias or the anorexics. So infantile anorexics are those who are very active, but they won't eat anything. Their appetite is very poor, but they are on the go. And those are a category of children we tend to see in our office practice. Do you all know what does a good feeding or eating practice means? So this is what it says. So you need to allow the child to explore, to just play with the food. And that's how they're going to get interested and they will be eating very happily on their own. So they'll be making a lot of mess, but you should allow them to do it, because then they will learn by experience. They get used to the textures. And you also have to be supervising them so that they don't choke on those new foods. And when they've grown a little bit older, sometimes it's sort of eating with other kids of that age may also help them to eat new foods which they would not eat when they're on their own. The thing you can do, if you take those kids along with you and do the shopping, get them actively involved in the shopping, buy fruits and vegetables, they will get interested in eating. Get them involved in cooking too. So this is one useful website from the University College of London, which I always feel is quite useful. And this talks about a lot about the various eating behaviors and what is the role of the children as well as the parents in this. And this is something I tend to use when the families come, and then I pick up that it is the parenting issues or the feeding issues are from the child. Then I tend to focus on this parental feeding style questionnaire that gives me an answer to what type of parenting style and what is the issue with the child. That's it. I always tell about this healthy, balanced diet in the form of a plate, and I call it as a rainbow plate. So it needs to have all colors. That's what we are saying. So it needs to contain different colors of foods, meaning all the types of food should be there on the plate to give us a healthy, balanced diet. And this is about responsive feeding style, what needs to be done and what shouldn't be done. So one of the key things, couple of key things are you feed your children only when they're hungry. Don't force your children to eat. You need to trust your children. Talk to them positively about eating practices. Eat with them as a family and establish a good role model to them. Establish set meal and snack times. Give them nothing but water in between the meals and serve a variety of healthy foods to them. Now we'll come to our first case. A 3-month-old baby girl presented with failure to thrive. The baby was born at term. Birth weight is 2.9 kilos. There were no antenatal and neonatal concerns. There's no history of consanguinity. Always been a poor feeder. On direct questioning, mother says that the baby is becoming tachypneic during feeding and sweating also noted. Weight has crossed down 2 centiles. So an examination, the baby appeared pale, tachypneic, and the oxygen sats were 95% in air. On auscultation, there was a great pre-systolic murmur, and the femorals were palpable. So what did I do here after this? As per a pediatric cardiologist opinion, it's done an echo, and it revealed a very large VSD. So the baby was commenced on diuretics. Once she was stable, she underwent surgery, and she made a good recovery. Case 2, a 3-month-old baby girl presented in view of faltering growth, born at term, birth weight was 2.5 kilos. Baby was reported to be born in good condition. Pregnancy was normal, except that the mother was an elderly primate. There was no history of any consanguinity. Mother stated that the baby has always been a poor feeder since the beginning. On examination, as you all can see, there's a stigmata of trisomy 21, poor tone, tachypnea, and auscultation and systolic murmur were heard. Faltering growth panel, including karyotyping, was sent, and echo was requested. So karyotyping confirmed trisomy 21, and the baby also had a very elevated TSH of 70, which is not a surprise. So Down syndrome, a trisomy 21, is associated with hypothyroidism. Echo showed a VSD, and then I've also done a genetics review for this child. So when I broke the news to the mother said, I always knew there is something not right with my baby in the last 3 months, although I was dismissed by a lot of healthcare professionals. So just a reminder or a recap of the stigmata of trisomy 21, which you are all aware of. So now the baby is a year old and is doing well. To a lot of families who have a babies with trisomy, they say life is a celebration with these babies. They're adorable. So the third case, 20-month-old boy presented with a concern of faltering growth, current weight 6.8 kilos, less than 3rd centile, height 68.5 centimeters, again less than 3rd centile. Mother said he is very weak and has significant abdominal distension. That was her primary concern to bring him to my clinic. Born at term, birth weight of 2.75 kilos, born in a good condition. Antenatal and neonatal history uneventful, and there is no history of any consanguinity. Gained weight until weaning started. Mother is very clear in that history. He was 6 kilos by 6 months of age. So he was doing quite well until the 6 months of age. On examination, the child appeared pale, wasted, there was an abdominal distension, and the child was quite irritable. So this is the picture of that little boy. This is the picture I'm trying to show with the cartoon. What are the features he is showing? So what do you all think is the diagnosis? So I've sent a faltering growth panel. His IgA TTG was positive, and his hemoglobin is quite low at 5.6. His vitamin D is less than 8 nanograms per ml, which is quite low. So his family, sort of because of the wanted to go and see somebody outside Rainbow. So they've gone and seen, and then they just came back to tell me that a biopsy was done on this child, and it confirmed celiac disease, where you will see the villus atrophy in these children. So the celiac disease again involves a multidisciplinary team approach, where a gastroenterologist, dietitian play the key roles, gluten-free diet and nutritional supplements, and the babies do quite well. You know, celiac disease is rare in this part of the India. However, the cases are on the increase. But for that families where there is a child with celiac disease, investigating for the celiac disease is going to make that difference to the family. This mother has been going between so many doctors before this diagnosis has been reached. So case 4, a 14-year-old boy presented with concerns of short stature, weight less than 3rd, and height is also less than 3rd centile. So there's a history of recurrent abdominal pain and diarrhea on and off is what the family was saying. There was no history of blood in the stools, no history of weight loss. Although take it with a pinch of salt, they've said he has always been very thin. An examination, the child was pale, systems were normal. His perineum examination showed anal tabs, and his SMR, he was prepubertal at age of 14. So it was a probable inflammatory bowel disease. So I've sent the growth, Faltering growth panel, and his bloods returned, which revealed a low hemoglobin, a borderline low albumin, and a raised ESR with elevated platelets. So referred him to the pediatric gastroenterologist, and then he's been managed and he's doing well. So case point, a 7-month-old girl referred for Faltering growth again, born at term, and birth weight is 2.76 kilos, born in good condition. There were no antenatal and neonatal concerns, no history of consanguinity. On examination, the baby appeared very weak. My gut instinct said something is not right with the child, but I could not put a finger on anything on that day. Sent up a Faltering growth panel, and then a few hours later, I received a phone call from the lab to say this baby's potassium was 1.8. Repeated again, and it was again low. So what did I do? I spoke to my pediatric nephrologist, who advised to get the child admitted, to do the potassium corrections, and also to investigate the child to find the underlying diagnosis. The urine analysis of this baby showed hypercalciuria, ultrasound abdomen showed nephrocalcinosis. So what do you think is the diagnosis? Distal RTU. Case 6, a 4-month-old girl with concerns of Faltering growth. The current weight is 3.2 kilos. This baby was born at 30-week gestation at a hospital outside Rainbow with a birth weight of 1.3 kilos. And there was history of consanguinity, first degree. And the baby was in NICU, apparently in the outside hospital for about 6 weeks. The NBS was reported to be normal by the parents. And the mother also showed me a karyotyping report, which was 46XX. In examination, the systems were normal, but there was an atypical genitalia on this baby. When I asked the mother, was she concerned about it? She said, yes, we were. But then I was sort of reassured by the doctors in the previous hospital. It's all okay. So what did I do now? Then a baseline blood sugar, electrolytes, blood pressure, which were all normal. I sent a CH panel out. So basically, these parameters are all increased. And I've also done an ultrasound abdomen, which showed uterus and ovaries. So what's the diagnosis? It's a simple virilizing CH because your electrolytes are all normal. So what did I do? I've started steroid replacement. At length, I've counseled the family regarding the risk of Edisonian crisis and also kept him informed of the emergency steroid plan, because steroids are a part of the fight and the flight mechanism along with the adrenaline. We've sent genetic testing bloods, reports awaited, and because there is a clitoromegaly in the atypical genitalia, it's primarily a clitoromegaly, which I could see. And the mother was so concerned that the baby can appear differently and people might be asking about it. And she requested a pediatric surgeon opinion as well, which I have sought. But a point of note here, now the sort of a new guidance is we should not do any genital surgeries on these babies, except for if it's a very simple cosmetical one, or if there is some problem, it's sort of, a single urogenital sinus is something we can operate, not otherwise not. We need to wait until the child can give the consent. So case 7, it's a 4-year-old girl, presents with concerns of short stature, weight 10 to 25th centile, height less than 3rd centile. There's a history of recurrent ear infections. On examination, there are no dysmorphic features, systems were normal. So one of the key message here, when a girl presents with a short stature and there's also a recurrent ear infections, one of the differentials you need to bear in mind is the Turner syndrome. So short channel panel sent, karyotyping returned with the Turner variant. What did I do? So screening investigations completed. This is because Turner's is associated with a lot of other conditions. So we need to look for those as well. If the child has those, we need to give treatment for those conditions as well. I've got a geneticist review and I've started the growth hormone therapy and counsel the family about the long-term surveillance. So in Turner syndrome, you tend to see the associations. You have to look for a partition of aorta because of the bicuspid aortic wall. The ovaries are very straight. At a later date, these girls are going to present with amenorrhea, and we need to do pivotal induction in these girls. They can have renal, like horseshoe kidneys. They have short statures. They have hypothyroidism. They have association with type 2, high blood pressures, overweight, obesity, osteoporosis, and visual issues like myopia, and strabismus, which is squint. They can have CSOM, chronic suppurative otitis media, scoliosis, dental issues. Celiac disease is again associated with Turner's, so they need to be on gluten-free if they have associated celiac disease. They can also have other autoimmune conditions like vitiligo. Case 8, a 10-year-old girl with short stature, weight 75th centile, height is very, very less than the 3rd centile, so quite well below the 3rd centile. Has always been short is what the parents have reported. No significant past medical history. On examination, the child had what we describe as growth hormone deficiency demeanor, which means immature chubby faces with a frontal bossing and a mid-facial hypoplasia. Frontal obesity and small hands and feet are very characteristic of these children. So what did I do? Short stature panel, including karyotyping. Bone age X-ray basically showed that the bone age was significantly delayed. I've done a growth hormone stimulation test where the child failed, i.e. what I mean by that is the growth hormone is very less than 7 nanograms per ml. And the MRI brain showed an ectopic bright spot, which again is a gold standard to make a diagnosis of the growth hormone deficiency. So what did I do? I started the child on a growth hormone therapy, counseled the family for the long-term surveillance. These are the few pictures of the growth hormone that's available in the market. The first 2 are in the form of a pen. The second 2 are in the form of injections, and the injections can be given with the insulin syringes. So one of the things I would like all the gender pediatricians to be aware of is now the growth hormone costs are coming down, and there is also a lot of central government health schemes via which they can be given free of cost. So these children have to be channeled correctly, and then we will be able to help them. And especially the injection forms of the growth hormone are cheaper when compared to the pen forms, but the efficacy of both of them is the same. So this is my last case, case 9, a 15-year-old presented with the concerns of short stature. When I plotted on the growth chart, the weight was 10th centile and the height is less than the 3rd centile. But the key feature is the moment I saw the child, there was a squint. And when I asked the mother, for how long has the squint been there? The mother said it's a recent new onset squint. And when examining the child, his SMR was pre-pubertal, mind you, he was at 15 years, and his systems was normal. So what did I do? MRI brain, I'll show you the MRI brain report in a minute. I've requested a short stature panel, and I've also asked for the baseline hormones. These were the bloods. The key thing here, the TSH was 1 and free T4 is 0.1. So if it was a primary hypoparathyroidism, you're going to have an elevated TSH and a low free T4. But if it's a central hypothyroidism or a secondary hypothyroidism, what you tend to get is like this. TSH is low as well as free T4 is also low. Cortisol is going to be low as well because there is a combined pituitary deficiency in this child. If you look at the LH, FSH, testosterone, they're all also very low because there's a hypogonadotropic hypogonadism. The prolactin 70 nanograms per ml is elevated in this child. So this is the MRI brain, which shows that there is a craniopharyngioma. So I'm going to say, hurrah, the teamwork always pays off at the end. And this is my sincere request to all the pediatricians who are listening to this talk. Please download this IAP growth chart, which is a very useful app where you can input all the heights and weights. And actually, you can advise the parents to download this app on their phones. And each time when they visit you, you can input the height and weight, because that will give you a visual cue what's happening with the child. And it's free of cost. So I need to finish off my talk by saying a thank you to my quintet, my 5 endocrine gurus, Namami Guru Charnabhyam, to my 5 bosses, and my specialist endocrine nurse, Jackie. And these are my references. And thank you. Okay, there is no easy way of determining the bone age. We all have to learn it, because if you ask the radiologist to report, they always give you a range of something like 2 years. So we normally tend to do it. There are 2 methods of doing it. One will be Grillage and Pile, and the other one would be with the Tanner Whitehouse. Thank you, Arvind, for the question. I hope I've answered your question.